As we are live, you can start off. I'm unmuting myself, okay, on YouTube. Thank you.
Assalamu alaikum and hello everyone. Hope each of you are doing great. Giving a brief introduction about myself, I am Dr. Shamama Sheeren. I have done my graduation from Al-Badr Dental College, Gulbarga, and my post-graduation in pediatric and preventive dentistry from AMS Dental College, Raichur, Karnataka. I am the host and moderator for today's session. The topic for today's webinar is nitrous oxide, clinical tips and perspective. And to speak on this topic, we have with us Dr. Sabah Sheikh, who is an exceptionally talented speaker. Dr. Sabah has pursued her BDS from Yanapova Dental College and Masters in Pediatric and Preventive Dentistry from Cots, Davangere. She is a gold medalist in pediatric dentistry from Rajiv Gandhi University of Health Sciences. Dr. Sabah is a certified nitrous oxide sedation practitioner under Indian Academy of Sedation Dentistry. Before moving on to Dr. Sabah, I would like to inform that we shall take up a question session at the end. I kindly request everyone to please post your questions in the chat box. Now, without wasting any further time, I request Dr. Sabah to take over the podium. Here we go right away with Dr. Sabah. Thank you. Dr. Sabah, can you please begin?
Thank you, ma'am. Thank you for the wonderful introduction. Let's begin with the presentation.
Yes, please, doctor.
I welcome you all to my presentation on nitrous oxide oxygen sedation, clinical tips and perspectives. As ma'am already told you, I'm from Mangalore, the city of beaches and ice creams. Wish we can have our next GDP workshop in this lovely city.
Yes, doctor, we wish.
This is where I practice along with my husband, who is an orthodontist. Now coming on to the introduction. Nitrous oxide, it's a non-irritating, colorless gas. It has a faint, sweet taste. If we inhale nitrous oxide, you can appreciate this taste as the gas passes through our oropharynx. We can appreciate the sweet taste as well as the smell. It is effective analgesic, and it's a very good anxiolytic, and also it has a very good partial amnesia effect. Now, the person who discovered nitrous oxide is Joseph Priestley, but the one who showed the anesthetic properties of nitrous oxide is Horace Wells, who was a very good practicing dentist, and he's conferred the title as the father of modern anesthesia. He was given his title around 20 years after his death. Now, is nitrous oxide oxygen sedation safe? Yes, definitely. When it is carried out by a trained professional using the delivery systems which are designed to prevent the adverse effects. The machines, the sedative units which we are using, they have some safety mechanisms in it which prevent the adverse effects. Now, the rationale behind this is, if you look at the composition of the air which we inhale, 78% is nitrogen and only about 21% is oxygen. So basically our body needs around 21% of oxygen. And these machines, almost all the sedation machines which are used in dentistry, they're designed in such a way that at any time you cannot deliver less than 30% of oxygen in it. So the oxygen concentration starts from 100%. Then the least amount of oxygen what you can give is 30%. So anytime you're giving them the oxygen much more than what we are inhaling. Now, can a dentist administer nitrous oxide oxygen sedation? According to Indian Dentist Act, it says that dentistry includes the various procedures carried out in the oral cavity. And the dentist can do all these procedures using any anesthetic in connection with any such operations or treatment. According to IDA, it states that appropriately trained dentist, he may use any number of pre and post-operative pharmacological conscious sedation techniques to achieve the anxiety reduction. And according to AAPD, the practitioner who uses this nitrous oxide, he should have appropriate training and skill, and also he should have proper facilities, personnel and equipment to manage any reasonably foreseeable emergency that can occur. Now, why is it clinically ideal sedative in dentistry? Compared to any other sedatives like the oral sedatives like midazolam, promethazine, or IV sedatives, if we compare inhalation sedation, that is nitrous oxide sedation, to that, the onset of action in nitrous oxide is very fast. Within 3 to 5 minutes, the action of nitrous oxide starts. And also the peak clinical action is very fast. Within 3 to 5 minutes, we can achieve the peak clinical action. This is in comparison to one which is given by IV sedation. Whereas if you go for oral sedation, it takes at least 30 to 45 minutes to act. And depth of sedation, which we can achieve, you can either reduce or increase the depth of sedation as we require during the procedure. This cannot be done with any other sedation except for in IV sedation, we can always increase the depth of sedation, but we cannot reduce the depth. We can give an antidote and just stop the sedation, but we don't have the ability to reduce the sedation. But in nitrous oxide sedation, we can do it. And the duration of action, we can tailor it according to our procedure. If we just need to extract one mobile tooth or just do a small filling, we can just sedate the patient for 5 to 10 minutes and complete the procedure. Whereas in IV and other oral sedation, once the sedative is given, it will have a specific duration of action, like 2 to 3 hours, and the patient is unnecessarily sedated for such long time. The recovery time is very fast. The moment you remove the inhaler, within 3 to 5 minutes after the procedure is complete, the patient can recover. And titration is possible. Titration is adding the smaller amounts of drug until we get the desired effect. Now, titration is possible only in inhalation sedation and IV sedation, but not in any other sedation procedures. And it's an outpatient procedure, does not need injections, and it's a very safe and no adverse effects. Now, although it is a very ideal sedative in dentistry, why is it not very popular among dentists? One is the cost of equipment. The initial cost of equipment is quite high. The machine, which is available at present in India, it costs nearly around 2.5 to 3 lakhs at present. It's not only about the cost of equipment. When we start our sedation practice, along with the equipment, we need some extra things, like we should have a portable X-ray. We should have an extra sedation, extra suction unit. So additional cost along with the equipments are there. And also the cost of gases. And the gases have to be refilled continuously. That's a recurring cost which is present. Then the equipment occupies space. Yes, the portable equipment, the portable system which is available, it occupies a small amount of space. And if you have to modify it so that it has a central supply, it will need a much bigger space. And it's not only that equipment occupies space. You need, once you start your sedation practice, you will you need to have a separate chamber for carrying out the sedation. So if you can see, this was my clinic before I started the sedation practice. We had 2 chairs side by side with the partial separation. But when you start sedation, we cannot carry out sedation in this open type of setting, where I'll be sedating one patient in one chair and immediately next chair someone else is working with a lot of distractions. The patient is not going to get sedated. So we had to modify our clinic. We took over one more shop beside that. We opened the wall here, and then we made a separate sedation area for the patients. Then it's not a very potent sedative agent compared to other sedatives, IV or oral. And degree of cooperation is required. For the patient to be sedated under nitrous oxide, first they have to be willing to get sedated. They should have it's not like general anesthesia or IV sedation where you just give it and the patient becomes completely cooperative. The patient should be ready to accept the mask and to sit on the chair. And also it requires training. The dentist has to be trained for the induction of inhalation sedation, and not only in the for inducing the sedation, but also the dentist has to undergo basic life support training, and that has to be renewed once in every 2 years. And also the dentist and the dental assistants will be continuously exposed to the deleterious effects of nitrous oxide. Now coming on to patient selection, who can be sedated? Any healthy adults and children who have a reasonable fear of dentistry, who can justify their fear of dentistry, we can sedate them. A child who is having a definitely negative behavior, who is not even ready to enter the clinic, who is continuously crying, who is not ready to sit on the chair, you cannot sedate such patients with nitrous oxide. Now, if you speak about age, what is the age limit? Few days back, we were having a discussion on this, about this in the group. So what is the cutoff age? If you see in the field of medicine, the nitrous oxide is used in children as young as 1 month of age. They use it for various procedures like venous cannulation, bone marrow aspiration, changing the wound dressings and all that. But there the scenario is different. They use nitrous oxide with the face mask, which covers both the nose as well as the face. But in dentistry, we have to work in the, where they cover both the nose and the mouth. But in dentistry, we have to work in the mouth. So we cannot use the face mask. We have to use a nasal hood or a nasal mask. And if the child is continuously crying, he's going to, the gases will pass out of the mouth. He's not going to get sedated. And also, since we're dealing with the oral cavity, we will, it can cause upper respiratory tract irritation. And this upper respiratory tract irritation is the one which leads to the complications. So in dentistry, most of the books recommend in children below 3 years, it is not recommended to do nitrous oxide oxygen sedation. Even in clinical practice, I do not do under 3 years, only in children above 3 years. And also children below 3 years will not have a cognitive ability to understand that they have to keep the mask and they have to let us do the procedure. So if you ask me, I will sedate any, what is the criteria for selection is, one is the patient should be able to hold the mask on the face and sit on the chair. He should understand what I'm saying, and he should be able to respond to me when I'm asking him something. If I tell him open the mouth, he should have the ability to understand. If the child is able to follow these 3 instructions, he can be sedated. Now, what armamentarium do we need before we start the sedation procedure? First of all, we need the sedation unit. Then we need the filled spare cylinders, gas cylinders. If we do not have filled extra cylinders, we cannot start the procedure. Then we need the mask of various sizes. At present, which is available in India is only 2 sizes are available from the concert dealers, the small and the medium one. The small one, it's little big. For children above 5 to 6 years, it fits well. But for very smaller children, 3 to 4 years, it does not fit well. So we have to stabilize it with a lot of tapes around it so that there's no much gas leakage. We need to have extra tubings just in case if there's any leak or crack in the tubing. We need to have a pulse oximeter to record the vitals. It is AAPD recommends, AAPD, according to AAPD, having a pulse oximeter is not necessary if the patient is being sedated with only nitrous oxide oxygen sedation. But I use it just to be more confident and to record the vitals. And BP apparatus, a digital BP apparatus. Initially, when I started my practice, I used to use it on all patients, but now I manage with only the pulse oximeter. Actually, applying the BP apparatus, the patient gets more tensed and anxious. So now I've stopped using that and I manage only with the pulse oximeter. Then you need to have a digital clock to check the amount of duration for which you are sedating the patient. You need to give oxygen for 1 to 2 minutes before administering nitrous oxide. And at the end of procedure, you need to give oxygen for 3 to 5 minutes. But for time observation, you need the digital clock. And weighing machine. Weighing machine It's more important when various other sedative medicines are used, like in IV and oral sedation. They calculate the dose looking at the weight of the child. But here in nitrous oxide, why I use this? I use it to weigh the cylinders, especially the nitrous oxide gas cylinder. The amount of gas which is present in the cylinders, we can assess it only with the pressure gauge which is present in the machine. But with nitrous oxide, the full nitrous oxide cylinder will show you 1000 psi, and the half nitrous oxide cylinder will show you 1000 psi. And when the nitrous oxide cylinder is 80 to 90% empty, it will still show you 1000 psi pressure. Only when around 10% of nitrous oxide remains in the cylinder, the pressure starts dropping. This is because in the compressed state, oxygen will be in the form of gas only. So whatever pressure you're seeing in the pressure gauge, it is the pressure of the gas. But whereas in nitrous oxide cylinder, since it is in the form of liquid, only last 5 to 10% of the gas which is remaining, that is showing the pressure which is shown in the pressure gauge is the pressure of that gas. So only when that gas starts reducing, your pressure starts falling. Basically, the pressure in the nitrous oxide will not fall until 90 to 95% of nitrous oxide is over. So when I send it for refilling, and when it comes back, if I want to be sure that the cylinder is half filled or fully filled, I need to weigh the cylinder. That is why I use it in the weighing machine. And you need to have a mouth prop. Sometimes when the patient is slightly deeply sedated, they will not be able to keep the mouth open. So for that, you'll need a mouth prop. Then you need to have a portable X-ray machine. So we cannot make a patient who is sedated walk around for X-ray. And extra suction unit. This is very important. In addition to the suction which we have in the chair, we need to have an extra suction unit. One is the most common reason for any complications is because of the upper respiratory tract irritation. Yeah. So we need to keep continuously using the suction. In these patients, even the saliva, if you're using even the rubber dam, the saliva gets pooled under the rubber dam. Even that has to be continuously sucked out. And also the most common complication which occurs is a vomiting. And when the patient is having vomited, we need to suck out the vomitus. For that, we need to have a suction unit, extra suction unit. And also to remove the exhaled gases, there is the outlet tube. I'll show you later when I tell about the parts that goes into the suction unit. Now the type of sedation units, there's one which are commonly used in dentistry is a portable one, and there's a central storage which is used in hospitals, and the central storage with the mobile heads. Now portable system, which is these are the imported ones, not very easily available in India. The Porter and Equitron and Matrix are the ones which are commonly used, and they're more expensive. And the one which is available in India is at present is the Concert machines. They come in two forms. The open type, open type is the one which I'm using. And there's one more, the chamber type. The only difference in this is that they just have added one extra chamber around it so that it looks aesthetically more pleasing. But people who are using this closed type, they tell that it's little difficult to change the cylinders in this type of machine. And this is a central storage with mobile heads. My machine, I have modified it so that it has a central oxygen supply. Now, I'll just tell you the reason for why I have modified this. During the sedation procedure, the amount of oxygen consumed at any time is much more than the nitrous oxide, because at the beginning we give 100% oxygen, then at the end we give 100% oxygen. And even during the procedure, normally the concentration of oxygen will be more than the nitrous oxide. So oxygen cylinder gets over very fast. So textbooks say around 2.5 to 3 cylinders of oxygen, we need 1 cylinder of nitrous oxide. But clinically, I've changed around 5 to 6 cylinders of oxygen for 1 cylinder of nitrous oxide. Now, refilling of this nitrous oxide, refilling of one cylinder will cost you 100 rupees for 800 rupees for nitrous oxide, and for oxygen it is 100 rupees. But the problem is this nitrous oxide refilling is not available in Bangalore. We have to send it to Bangalore. It gets refilled in Bangalore and then comes back. Whereas oxygen refilling is available in Bangalore, but it is in the industrial area. It is out of the city, around 15 kilometers out of the city. Although the refilling cost only around 100 rupees, but going and coming, the logistic is costing me more than the refilling of the gas. And it's getting over every 2 to 3 days, it gets over. So I can't keep running to get the oxygen refill every now and then. That's why I modified the unit so that it has a central oxygen supply. Now coming into the parts of sedation unit, I've just made a small video in my clinic about the sedation, parts of the sedation unit. Assalamu alaikum everyone. I'll be speaking about parts of concert machine which I'm using in my clinic. This machine is actually a portable machine with cylinders attached to it. It has a rolling stand. It comes with 4 cylinders, the 2 nitrous oxide cylinders on left side and 2 oxygen cylinders on right side. I have modified this system so that I can have a central oxygen supply for this. Now coming into the parts, the cylinders are attached to the stand with the help of yoke. We need to open this and to change the cylinders. The next part is the pressure gauge. The pressure gauge for nitrous oxide and oxygen. Now this will show the pressure of the amount of gas which is present inside the cylinders. The next part is the regulators, or they're also known as reducing valves. They reduce the pressure of the gases coming out from the cylinder and make it safe to be delivered to the patient. The next part is the flow meter. The flow meter will measure the amount of gases which are in motion or which are passing. This is a knob. So as we turn the knob, the gases start passing. Now only the oxygen is going because I've kept 0% nitrous oxide. As the gas starts flowing, the ball raises. This helps us to establish the flow rate. The flow meter has markings from 0 to 0% of nitrous to maximum of 70% of nitrous oxide in this sedation machine, in this concert machine. We cannot give more than 70% of nitrous oxide or less than 30% of oxygen. The next part is the oxygen flush, which used in case of emergency, just to deliver 100% oxygen. The next one is the gas delivery system. It is delivered to the patient with the help of tube and the mask, nasal mask. Okay. Nasal mask. It will have an inlet and the outlet. The outlet pipe, the outlet tube of the mask will be connected to a scavenging unit. The scavenging unit which is used in my clinic is that it goes into the suction tube, the high volume suction, the extra suction which is used, it goes into this. So when it is activated, it will run. That's all about the concert machine. Yeah. Just to add a note on that inlet and outlet tubes which we attach to the mask, both the inlet and outlet tube, they look same. The only difference is the length of the tube. The inlet tube is longer and the outlet tube is shorter. So when we fix it onto the mask, if we interchange this tube, the patient is not going to get sedated. I had done it once and then I was wondering why the patient was not getting sedated. So that thing has to be remembered. Now, the part which is missing in the Indian machine, the first and foremost part which is missing is the reservoir bag. Actually, reservoir bag, it's a very important part because it helps us to assess the patient, how the patient is breathing. Here it is missing, and we can assess only by looking at the patient's chest movements. And they have not provided any provision to attach it. And even the alarm, the physical alarm, there's nothing, there's no bell or ring which will ring when the oxygen or nitrous is over in Indian machine. I think it is present in the textbooks say it is present in the imported machines. Now, coming on to the main part, the administration of nitrous oxide oxygen sedation. Having a pre-treatment visit is very important. A patient can't call you over phone and tell that they want to come for a sedation, especially if it's the first if it is a first sedation visit. It is very important to have the pre-treatment visit. So in pre-treatment visit, we have to assess the patient as well as the parent. In patient, we have to assess their behavior. If the child is definitely negative, having a definitely negative behavior, is not ready to enter the clinic, crying continuously, you will not be able to sedate such patients. And also you need to have a parent, know what are the parents' expectations. Normally what happens is the patient along with the parent would have gone to some other dentist. They would have tried to do some procedure and the child would not have cooperated. And if they know that you are practicing sedation dentistry, they tell them that there is something like a laughing gas which will make your child really cooperate well. So when the parents come, they come with the expectation that when I place the mask and give nitrous oxide, the patient is going to be extremely cooperative. They're going to just sleep off during the procedure, and there's not going to be any temper tantrums. So you have to be realistic with the parent. You have to explain them what it is. It is not a magic gas. It is only going to calm your child down. Some amount of cooperation is required by the child. You have to explain. Most of the parents will think that once you give nitrous oxide, they do not need injections. They do not need local anesthesia. But that is not true. You have to explain them that patient will feel pain, but the amount of discomfort will be less. So we have to give injections. We have to give LA. And some amount of crying is also expected from the child. And and also one more thing parents expect is that if they have full mouth rehabilitation, a lot of caries, they expect that under sedation, everything will be done in one sitting or two sittings. But that is not the case. You cannot sedate a patient more than 45 minutes. So that has to be clearly told to the parent about the time constraint also. And you have to discuss the risks of the procedure. You have to explain the patient that there can be vomiting during the procedure and also after the procedure. The patient might have slight headache after the procedure, which is normal. And the benefit of the procedure, both to the patient as well as the dentist, has to be discussed. That in a child who is much more calmer, will be able to work better. Then be realistic and then explain the cost. Obviously, the treatment cost for the procedure under sedation and without sedation are not the same. So this has to be clearly discussed about to the patient in the pre-treatment visit, so that at the end of the day, we are not at loss. Then pre-sedation instructions. Fasting is recommended before the sedation procedure. The milk and solid foods should be stopped 4 hours before the procedure, and until 2 hours before the procedure, you can take water and any plain juice. Like I normally tell them, you can give them any plain juice without the pulp. You can remove the pulp of the fruit and you can give watermelon juice, orange juice. That can be done. And emphasis should be placed on fasting procedures, because if the child comes with a full stomach, he is going to vomit during the procedure. Then you have to explain the kind of behavior we expect from the parent during the sedation procedure. Normally, what happens is the patient would have been adequately sedated. The parent will be standing in front of them. And normally, when we are about to inject or give LA, suddenly the parent will say something like that: don't move, open your mouth, don't close your mouth, it won't hurt. Or they might just change their facial expression. Although the child is sedated, they can understand, they will be aware of the surrounding and what is going on. And when the parent says something like that, they will sense the fear and they start crying out. So that has to be clearly told to the parent that the only person speaking during procedure is the doctor, and you cannot interfere during the procedure. And also the bystander, it is better to allow only one person in the operatory. The more the bystanders, the more distraction. It's better, you have to tell the patient if the patient is having younger siblings, you inform the parent that not to get the younger siblings during the procedure. And also having a bystander is important even while treating adults. There is something called a sexual phenomenon which develops when the patient goes into a slightly deeper state. Because of the euphoria effect, they have a slightly sexual phenomenon which can develop because of the dreamy state. In US, there have been cases where the patient has registered, they have sued the dentist saying that there was a sexual misconduct from the dentist. Especially this has happened when the treating dentist was a male and it was a female patient, and they were alone in the operatory. So in order to prevent that, it is better to have, especially if you're treating an adult patient of opposite sex, it's better to have one bystander ready, or you should have your CCTVs installed. And the contact lenses, we should advise not to wear the contact lenses during procedure in adults, especially because the gas leakage around the mask can irritate the eyes. And clothing, books say that it's better that they don't wear very tight clothes which make them difficult to breathe. For me, normally what I have observed is this girls, they wear these frocks with a lot of frills around. Since my machine doesn't have the reservoir bag, I have to just look for their chest movement to see their respiration. So if they're wearing that kind of frock, then it becomes a little difficult for me to assess their breathing. Now, the day of administration. So on the day of administration, 3 things have to be ready. The doctor has to be ready, the clinic has to be ready, and the patient has to be ready. Now, the doctor has to be ready. Now, the doctor, during the nitrous oxide sedation procedure, the most important thing is the observation of the patient. In nitrous oxide sedation, we don't have any one specific parameter like, okay, this is a BP, this is a heart rate, so patient is sedated to this level. It is only observing the clinical signs and symptoms of the patient. We will come to know what level of sedation the patient is in. For this, the doctor has to be both physically and mentally alert. So if we are stressed, if the doctor is having a common cold and we have taken a lot of antihistamines, we are sleepy, we are drowsy, we cannot make a proper clinical judgment. So in such cases, it is better to postpone not to take up the sedation case on that day. And mental health, even the doctor has to be mentally calm, peaceful, even to carry out the procedure, and also to execute if there is any emergency, to manage the emergency. Like if you're stressed about anything, if your child is not well, you are in a rush to come back home. In such cases, it is better to avoid taking up the sedation cases on that particular day. Now, appointment time. The early appointment is early appointment in the morning. It is better. It is better for patient because keeping child on fasting for 4 hours, it is a difficult task for the parents. So normally what I do is most of my sedation appointments I keep early in the morning, so they get the child directly from the bed. In that way, it's easy for them to maintain the fasting. And also, even as doctors, we'll be more fresh, we'll be less stressed early in the morning, and we can finish our procedure. Sedation procedure. And once the sedation procedure appointment is done, we are also relaxed for whole day. Or one more option is you keep it as a last appointment of the day, where you don't have to worry about the other patients waiting and you are not in a hurry to finish the appointment. And appointment times, if we cannot assist how much time, although they tell the clinical onset is within 3 to 5 minutes, each patient is not going to get sedated within that 3 to 5 minutes. A patient who is one patient can get sedated within 5 minutes, one patient can get sedated after 15 minutes or after 20 minutes. Sometimes I take more time to sedate the patient than to do the procedure. So the time which is required is very variable. So we have to take this in mind and give the appointment time. we can never be in a hurry to finish the sedation procedure, because sedation procedure, and also we should, if you are planning that the appointment is going to take around 30 minutes, it's better to keep at least 15 minutes as a buffer time. So that if in case the procedure is patient is taking slightly longer time, or after recovering, if the patient is not completely recovered, you want to give oxygen for 5 more minutes, you have that buffer time available with you. And better to avoid in between appointments where you have just finished 5 patients and you are doing one, you have to do sedation. After that, you have some 3-4 patients. That is more stressful. Then is the clinic ready? It's not only the dentist who has to get ready, the entire clinic setup has to be ready to carry out the sedation procedure. First is, if you have a sedation appointment next day early morning, you inform your staff that there is a sedation procedure tomorrow morning, so that even they are mentally ready for the procedure. So first you have to prepare the equipment. Before you start the procedure, when you train your staff, they learn to do all these things. They learn to check if there is gas in the cylinder, to turn on the gas cylinders and all. But even if after they tell you that the gas is there, I have put on the cylinders, it is always better to cross-check. Because when you turn the cylinder, there's nothing which shows that the cylinder is open or closed. We just have to turn it. Only when you tighten it, we know it is closed. And when you open it, we know it is open. So always turn on the cylinder. It may sound silly, but this mistake often happens, especially when we are stressed. Initially, when I started my sedation procedure, sometimes I used to switch on the oxygen cylinder and I used to forget to switch on the nitrous oxide. And then I used to keep wondering why the patient is not getting sedated. Then tapes ready. That is, if the mask is not adequately fitting, to fit it around the patient's nose. And check for any leaks. If there's a leak of nitrous oxide, you will come to know immediately because of the smell. You can appreciate the smell very well. When you move from one room to other, you can appreciate it very well. And or also you can, by the sound of the leaking gas sound, you can make out if there are any leaks. Now, where do we keep the sedation unit? It is kept behind the patient, so that patient is not, patient cannot see it directly. The instruments have to be ready. If you're carrying out multiple procedures, tell your assistant to keep all the instruments ready one by one. And this will avoid unnecessary wastage of time. See, longer you're sedating the patient, the more chances that they might go into deeper sedation and more complications. So our aim should be to use the least amount of sedative and complete the procedure in the least amount of possible time. Avoid unnecessary noise. And phones should be in silent, especially the parent's phone, because the child will be very familiar with the ringtone. They'll be adequately sedated and suddenly the phone starts ringing. They just wake up. So we should advise even the parents as well as the doctors and the assistants' phones should be in silent, and consent forms signed. This is a very important.
Concentration, you mean to say, doctor? Basically, the concentration of the patient.
Yes.
Yes.
Then the consent signs form should be signed. Now, as I told you, our main aim should be to use the minimum amount of sedative to get the desired effect. If the patient is more stressed, when he comes and sits on the chair, it will take longer time to sedate the patient, and we need more amount of nitrous oxide. So all these things which can evoke any anxiety in the patient should be kept away from the child before he comes and sits. Normally, when we tell the assistant keep things ready for extraction, they'll come and keep all the forceps, LA, everything in front, and the child sees that. So before he even sits on the chair, he's more stressed looking at this. So all these things should be kept out of sight. Now, is the patient ready? First and foremost, make sure that the patient has used the washroom. This is because you cannot, if the child wants to go to washroom, you cannot make a sedated child go to the washroom. So, and also I've observed that because of the sexual phenomenon, even in children, they touch their genitals during the procedure. And the parents say that they want to go to washroom, they want to go to washroom. So just to make, I know that it is because of the sexual phenomenon, but parent will not be aware of it. So just to make sure that it is not because they want to go to washroom, we should finish this procedure preoperatively. Then review the medical history. Even if they don't have any medical history, but the day they come for sedation, they might have cold, they might have a running nose. Check for that. Record the vitals using a pulse oximeter. What I have observed is the BP. When I used to record the BP of the patient during the procedure, there was not much change in the BP. But there is definite change in the heart rate. When the patient comes and sits and you put the pulse oximeter, especially in children, the heart rate will be very high. It goes around 105, 110. And you start giving them oxygen because it's tensed. When you start giving oxygen, the BP, heart rate will be seen. But once you start giving nitrous oxide, even with 10% nitrous oxide, the heart rate starts falling. And then it comes to the normal level. Then check if they're wearing contact lens and hairstyle. This is especially important in girls and women. If they've tried the high bun on their head or a high pony, which is not, and they're not comfortable sitting on the chair, it is better you adjust to all that before you put the nasal mask. But because after you put the nasal mask, after patient is sedated, then doing all that adjustments becomes difficult. Then parent positioning. Parent positioning is very important. First and foremost, I told you it's better to keep parents out of, not in direct vision, not in direct line of vision, in order so that they don't get more stress looking at the parent. And if the patient wants to sit on the parent and get the procedure done, it's all right. We have to compromise with our position. But this is a position which I normally use in a slightly cooperative children. I make the parents sit near their legs and I make them slightly tap the legs so that the child knows the parents are present and they're comfortable. Now, administration of nitrous oxide. So you have put on the mask and first you record the vitals. Then you look for chest movements. As I told you, our machine is not having the reservoir bag. So we have to, before you start the oxygen itself, check the chest movement, see how is the chest movement, how they are breathing, and then you start with the flow rate. Now the flow rate for adults is around 6 liters of oxygen per minute, and for children it will be around 3 to 4 liters. And once you start the flow rate, then again look at their chest movement. If they're breathing too much, if they're breathing less, if they're taking deep breaths, that means the flow rate that you have given is not enough. You will have to adjust the flow rate. If the chest is overinflated, they're not able to breathe. That means the flow rate what you're given is too high. You need to reduce it. And then you give oxygen for 1 to 2 minutes. And then you start with the titration. First, you start with the 10% of nitrous oxide. Then looking at the signs and symptoms, you slowly increase the nitrous oxide dosage. Now, observation is the key for all this. Now, coming to the clinical signs, so this is normally how the patient will be when they come and sit. They'll be very tensed. They will be holding their hands across, or sometimes they'll be holding the chair armrest very tightly, and they'll have the legs will be crossed. Around this, I noticed after I started the sedation practice that around 90% of the patients will be sitting like this. They'll be very tense. They'll always have a crossed leg. And then once you start with the nitrous oxide, even with 10% nitrous oxide, the first and the foremost clinical sign which develops is a tingling sensation of the extremities. So when they get that tingling sensation of the extremities, they just start opening and closing their hands and legs, or they just start moving their legs. This small video, this is one of the first signs which develops. They just start moving their legs specially. And then you have to observe for their eyes, their eye movements. Then as you increase the concentration, the eye movements start reducing. The blink rate reduces. They'll have a slight sleepy appearance. The face will become more relaxed. And sometimes they'll also have a starey appearance. They will start staring at you, or they'll just start staring at a wall or at a ceiling. When the child gets slightly sedated, sometimes they'll be holding something tight. If they're holding the armrest, they relax it. Their hand starts dropping. And also the legs which was crossed becomes uncrossed. And also when you speak to them, the child will respond to you. The child was previously who was not ready to open the mouth. When he's adequately sedated and you tell them open your mouth, they will open your mouth. They will start following your instructions. And when you ask them some questions, they will respond, but their speech will be slightly delayed, they'll be slow. Then begin the treatment. This video is added, just observe the video, then I'll tell you a few clinical tips which I do, which I follow. Here I'm applying topical gel before the procedure. We have to remember that nitrous oxide, it's not a shortcut for anything. You have to follow all the procedures. You have to give topical, you have to give LA before you begin the procedure. Now, after I apply topical anesthesia, before I inject, just to make sure that the patient is in an adequate state of sedation and is not going to overreact when I inject sedation, I just distract them by using suction. Normally, children get very irritated with the suction and they just start pulling it out or they cry. So using suction before I inject LA just gives me a little more confidence to begin the LA administration.
As you said, Dr. Sabah, that we cannot skip any procedure, that we have to apply topical anesthetic, we have to apply LA, basically because it is a weak analgesic.
Yes.
Nitrous oxide. Yes. Yes.
When I'm giving LA, you can just look at the patient's eyes. She is feeling the pain, she is feeling the discomfort, but she will not respond in that aggressively. She will just close her eyes. She might just tighten her eyes. Some children even cry during the LA procedure, and that is absolutely okay. This was a very uncooperative child who was not even ready to sit on the chair. And then slowly she had at least agreed to come and sit with the tell-to-do technique. And one more thing what you can observe is I have not draped the patient in this. I do not drape the patient until I start the procedure, because I just want to observe. Once I drape the patient, it becomes a little difficult to see their chest movements.
That's the importance of continuously monitoring ABC
Yes.
during the entire procedure, doctor.
Yes.
The airway breathing.
And if I have any doubt, even during the procedure, that I'm not able to appreciate the chest movement, I will put a very small drape only near the neck, not over the chest. Now, one more thing what we have to tell is when we begin the titration, initially when we have to give a LA or we have to do a slightly painful procedure, I sedate them to a little deeper state. That's called the induction stage, where I finish the painful procedure. I might have given around 30 to 40% of nitrous oxide. And once I finish the painful procedure, then I reduce the dose of nitrous oxide. And then I just have a maintenance dose. In the maintenance dose, I just need a slight cooperation from the patient, because once the patient, especially children, if they do not feel pain, they will cooperate. So this is a maintenance phase when I'm just doing some restoration. You can appreciate the child's eye movement. She has a stare in this. And it's very important to observe both the patient as well as the sedation unit continuously during the procedure. It's not that we just start the procedure and we forget about everything else. We have to keep looking for the chest movements, even keep looking for the machine. If the flow rate is fine, if the percentage of what percentage of nitrous you are in, what percentage of oxygen is being delivered. And also when rubber dam is used, we have to keep using suction under the rubber dam. So there's no pooling of the saliva. And once the procedure is complete, you have to terminate the nitrous oxide. Now, how do you stop the flow of nitrous oxide? The textbooks say that we don't need to do a reverse titration. We don't have to reduce gradually. We can just stop and we can directly come to 100% oxygen. But if you're in a slightly deeper state, like 40 or 50% nitrous, and if you suddenly stop nitrous, I've seen that the patient will wake up with a sudden jerk. So in order to avoid that, normally after I finish the painful procedure, I reduce it slightly. If I had given LA at 40%, and I will do a little other procedures at 30%, and I know I'm going to finish procedure in 10 minutes, I will slightly reduce it further, make it 20%, and then I reduce it gradually. Now, when do you discharge the patient? Once the procedure is complete, you have to give 3 to 100% of oxygen for 3 to 5 minutes in order to prevent diffusion hypoxia. This step, it cannot be skipped, it has to be followed. And then you do some tests to be sure that the patient is in a right state to be discharged. There's a modified neurologic test where you can ask the patient to touch their little finger on the nose. That is just to assess their psychomotor ability. And also there's something called...
Explain, sorry to interrupt, doctor. Can you please explain diffusion hypoxia for our viewers?
Diffusion hypoxia is since when you stop the flow of nitrous oxide, it diffuses more rapidly compared to oxygen. It diffuses more rapidly and from the blood, and it enters into the alveoli. And since there's only nitrous oxide, the patient feels hypoxic. So in order to prevent this, you have to give 100% of oxygen for 3 to 5 minutes.
Yes, doctor. Please go ahead. Thank you.
The trigger test, there are a few dots which you have to join. This has to be done pre-sedation and post-sedation, and then you have to compare the pictures. But clinically, what I do is I do what is appropriate for the age of the child. If the child is around 3 years, I just ask them to show thumbs up, or I give them a high five. And if the child is around 4 to 5 years, where they know to count, I just show my fingers and ask them how much is this, how much is this. If the child is a little more like around 7, 8 years, I ask them some simple calculations. I show 5 plus 2 or 3 plus 2, how much is it? That is how I assist them. And that when you do that, even the parent feels more confident that the child is okay. Then record the data. Like a general anesthesia procedure, you have to record the time of the procedure, the duration of the procedure, the concentration what was used, the procedure which was carried out. That is for any medico-legal reasons. And also it will help us to assess our progress. So if I check my data now, I've seen that when I had started the procedure, I used to sedate patients around at 50 to 70% also. Then as I got used to the nitrous oxide oxygen sedation, now most of my sedations will be around 30 to 40%. And after the procedure, you have to close the equipments. Then who we do not sedate, one is a claustrophobic patient who is not ready to accept the mask. The patient on cancer therapies, that's a bleomycin therapy.
For claustrophobic patients, we also have certain modifications, doctor, in the nasal hood. We can be using them.
Okay.
Please highlight on that.
On the nasal.
Yes, doctor, please carry on.
Yeah, we can use that nasal cannula instead of the mask.
Exactly, doctor. Exactly.
Then the bleomycin therapy, the cancer patients, because it's told that the excess oxygen which is given, it can cause a lung damage. And patients on folate deficiency, who have folate deficiency or methylene tetrahydrofolate deficiency, they have in them, there is if nitrous oxide is given, they will have an increased bone marrow depression. So it is advised to, it is one of our absolute contraindication. And severe behavioral problems where the child is if they're in a pre-cooperative stage, if they're extremely negative behavior, we cannot sedate them. And special children who do not have the cognitive ability to understand the procedure and keep the nasal mask, we cannot sedate them. And also it's told that in children with autism, they have this methylene tetrahydrofolate deficiency. That is one reason we should not sedate the patients with autism. And upper respiratory tract infection, if the patient is having cold, cough, blocked nose, it is difficult we cannot sedate those patients. Some tell that if there is a slight nasal blockage, we can use the nasal decongestants and use it, and the sedation can be carried out. But generally, if they have any of these symptoms, I avoid sedating such patients. And mouth breathers, if it's a habitual mouth breather, you can just use a rubber dam and you can carry out the sedation procedure. If there's an anatomic mouth breathers, deviated septum or a large nasal polyp, or if they have adenoids are enlarged, then you cannot sedate. Sedating those patients is difficult. There is a modification technique which is given where they put the rubber dam and they pass the tubing directly into the oropharynx from under the rubber dam. So that's called insufflation. But there's also a controversy that if the patient is having enlarged adenoids and we sedate them, if there is an emergency and we have to intubate the patient, then it becomes very difficult to intubate them. So in such cases, it is better to avoid sedating such patients. Recent ear infections, the patient, nitrous oxide has the ability to expand. It is when it goes into any closed spaces, it expands, and that causes severe pain. So in patients who have this ear infections or sinus infections, it can cause severe pain. In such patients, it's better to avoid. And patients with intraocular bubble, it can cause nerve damage because the bubble in the eye, it can expand and it can cause a nerve damage. And pregnancy, first trimester of pregnancy, because it causes teratogenic effects, it has to be avoided. It's an absolute contraindication. Actually, it is used in second and third trimester, it is used in the Department of Gynecology. But before we sedate, it is better to take a consent. Now coming to over-sedation. Now you have sedated the patient too much, what is required. So what happens during over-sedation is the pharyngeal and laryngeal reflexes, protective reflexes will be lost. And because of this, complications can occur. So we should always try to avoid over-sedation in patients. What are the most common causes is improper titration. The child is crying too much, you would just want to sedate him. Instead of starting with 10% nitrous oxide, you just start with 50% nitrous oxide. That can cause over-sedation. Or the patient is not getting sedated, you are in a hurry, you have patients waiting outside, you want to sedate the patient and just finish the procedure. You do not follow the titration and you just give a high dose. That is improper titration. Then long procedure. 30% of nitrous oxide for 30 minutes is okay. But 30% of nitrous oxide for 1 hour, the patient is going to go in a over-sedation state. So if you have to carry the procedure for long time, you have to reduce once the induction phase is reduced, just for maintenance, you have to reduce and keep it. Then the lack of stimulus. You have sedated the patient in the induction phase. Since it's a painful procedure, you have given a high 40% nitrous oxide. And after LA, you're just waiting for LA to act for 5 minutes. And you have kept the patient in 40% nitrous oxide for that continuous time. And you're not having any stimulus with the patient. The patient will go into the deep sedation stage. So in such cases, what you have to do is, you have to either reduce this dose, or you have to keep speaking to the patient so that the patient does not skip into the deep sedation. Then sleepless nights, the child around this commonly occurs, I've seen in children around 3 to 4 years. They would have had very bad pain at night. They had not slept throughout the night. They come for the procedure, and the moment I give them 10 or 20% of nitrous oxide, they just go into sleep. And I have actually given them LA in this during this sedation with 10 or 20% nitrous, and then removed the sedation and then done the entire treatment. So that is sleepless night. Then if they're very tired, it's easy to sedate the patient. The moment we keep them, they will fall asleep. Now, what are the indicators of over-sedation? They continuously close the mouth. They will not be able to keep the mouth open. This is one of the most important signs. The moment they are not able to keep the mouth open, it is better to reduce the dose of nitrous oxide. And they start breathing from the mouth suddenly. The nausea. The moment they'll have the vomiting sensation, and they do not respond to you when you're speaking. They become unresponsive, they lose control, and which commonly I've seen in children is when they get over-sedated, they either laugh too much or they cry uncontrollably. These two things very commonly occurs. Now, how do you manage oversedation? First and foremost, do not panic, and then lower the dose of nitrous oxide. Lower it by around 10%, and they will come out of oversedation. The patient is, and also give a physical stimulus. You either tap the patient. Once when I started the procedure, once I had given around, it was only 50%, and the patient had gone into deep sedation, and I tapped him. He was not waking up. I was actually panicking, but we should not panic. And then I had to literally, with the probe, I had to prick him to just wake him up. And then he woke up. Then complications. The first and foremost, the most common complication is vomiting. When the patient comes, you would have asked the parent, is the patient on NPO? They will tell yes. But the moment you keep the suction, or you start the procedure, or you start sedating them, they will have nausea. And when the parent sees this, and then you ask them again, is he on empty stomach? Then they'll tell you, no, he just had a biscuit, or he just had, on the way, he just had an ice cream. So this is one of the most common reason for vomiting. So what do you do when the patient agrees that there is a food in the stomach, that they have not followed NPO? One is, only thing is you stop the procedure, because what happens is you might have to carry out just a simple extraction. You would have completed it. But if we allow this, today you have to do a simple extraction. Tomorrow the same patient might come with and he might need sedation for 45 minutes. And if the patient, when he knows that doctor is going to carry out the procedure, even if we don't follow NPO, next time also they will come with the same full stomach. They will not follow your instructions. Or your next patient might be their relative or their reference, and they will have the discussion that it's okay, the doctor will tell not to eat anything, but it's okay, last time we had, nothing happened. So it is a problem for us. So just to make sure that the patient follows instruction, even when they agree that they have not followed the instruction, they have had something, you stop the procedure and tell them that we cannot do it, we will do it next time. The second reason is oversedation. Then the diffusion hypoxia, it can be prevented by giving 3 to 100% oxygen. Then toothache associated with sinus, as I already told you, because of the gas diffusing. Vertigo, same reason, when it expands inside the ear, they might have slight vertigo, and the blood bowel discomfort. Now, the rare complication is death. Actually, nitrous oxide is used in dentistry from around 170 years. And till now, there has been no report of death caused by nitrous oxide. There was one report of laryngospasm, which was in 2015. It occurred in a baby who was 16 months old, and he was sedated with 70% nitrous oxide. And that was for medical reason, not in the field of dentistry. And silent regurgitation and aspiration, it can occur if the patient is having food in the stomach, or if the saliva gets pooled too much in the mouth. So that can be avoided by using suction continuously. Now, how do you manage an emergency? The managing of emergency with nitrous oxide is similar to any other management of any other emergency during any other dental procedure. The first and foremost, both the dentist and the dental staff should be trained to manage an emergency. You should assign a role. Each role should be assigned to your receptionist, to your dental assistant. They should know what to do during an emergency. The emergency contact numbers, the contact number of your nearest hospital and the ambulance should always be in hand. And also the emergency kit, it should be ready, and you should know where it is. You should have the extra, when the serious complication which can occur is patient can stop breathing. So our role, we don't have much role to start the breathing in that. So only our aim should be, we should be able to provide a continuous respiration support to the respiratory support to the patient until the trained personnel come. So we should always have an extra oxygen cylinder which is present. This is a cylinder, extra oxygen. This is not the same cylinder which is present which is attached to the unit. This is a separate oxygen cylinder for providing oxygen in case of emergency, along with the face mask which can fit all the patients. Now, to conclude, nitrous oxide oxygen sedation, it's as a technique for sedation, it is very useful and safe, but it's not a magic wand. It has to be used as an adjunct to other behavior guidance techniques. Like any other dental procedures, the induction of inhalation sedation also has a definite learning curve with a lot of disappointments and discouragements. But when it is used and also the complications can and do occur, but when it is used by a trained personnel with a good sedating unit, all these complications can be avoided. Thank you.
Thank you, Dr. Sabah. I think we shall now begin with the question and answer session. Shall we go ahead?
Yes, ma'am.
The first question is from the GDP professionals. What are the different techniques to achieve moderate sedation? Which one do you prefer and any particular reason? That is why. So basically they want to know which are the different techniques to achieve moderate sedation and which one do we prefer and why?
Okay, ma'am, oral sedation can be used. So if you ask me which one do I prefer, I prefer nitrous oxide oxygen sedation because it is much more safe and the effects are more reliable. Before nitrous oxide, I have used oral sedation. I've used I'm not getting the name of the syrup, which is not available now. We used to use that syrup for oral sedation. It actually contains midazolam. So that was being used. But in that, as I told you, one is the onset of action is long. Okay, you have to, after you give it to the patient, after you make the patient drink it, you have to wait for about 30 to 45 minutes. And you cannot alter the depth. So whatever sedation the patient is in, we have to try to carry out the procedure with that only. We cannot alter the depth. And also, even after you complete the procedure, before you discharge the patient is still in that sedated state. So even the parents are a little worried, even we are a little worried until the patient goes and they completely recover. So I have used that, but I do not prefer it. And
maybe is it pedichloride, madam?
Yes.
Pedichloride?
Yes.
Is it pedichloride?
It is pedichloride. It's not available now. I don't have banned or something.
Okay, ma'am.
Thank you, sir. Thank you for reminding.
So shall we take up the next question, doctor?
The other types of the sedation, moderate sedation techniques is transmucosal and intravenous.
Yes, doctor, we prefer, why do we prefer, which one do you prefer the most is the asked question? Dr. Sabah?
Yes,
amongst all sedative procedures.
Yeah, because I can carry out this procedure in the clinic. I do not need an anesthetist. With intravenous,
I think it has got a very quick reversal action.
Reversal action, and we are confident when we are happily sending the patient walks by himself and goes. We'll be more confident. And
the inducing time is also very quick as well as the reversal time is very quick. It's both the ways.
Yes.
Can we take up the next question? The next question is from Dr. Nadeem Ahmed. So do you send for evaluation to an ENT to check for adenoids? The patient that we want to go for conscious inhalation sedation.
Yes, if there is normally when I take up this case, if I feel there is any medical history, I send it for a consent. If there is enlarged adenoids, I would ask for a ENT evaluation. And if I actually play it safe, if I have any doubts, if I feel it's not an ideal candidate, because I've just started with the sedation, I've just finished around 100 cases, so I'm not that well versed in this. So at present, if I play it safe, if I feel it's enlarged adenoids, I don't take up the case. I try to use other behavior modification techniques, but I don't prefer nitrous oxide.
Next question is, how do we prevent over-sedation or excessive sedation? Do we have a standard titration protocol for moderate sedation? The first question, how do we prevent over-sedation or excessive sedation?
This over-sedation, there's no more one titration technique. See, we cannot tell today, I'll just tell you, if a patient comes today he gets sedated with 30%. it's fine. He's getting 30%. And tomorrow he comes, he's more relaxed. He can get sedated. If I thought, okay, yesterday I gave him 30%, today I'll give him 30%. He's going to have sedation. But today he might get sedated with only 10%. So the clinical, the sedation level, it varies from person to person, and also in the same person, it varies on different days. So there's no standard titration protocol. That is why clinical observation is very important. Okay, only by looking at the signs, the patient response, we will come to know if the patient is adequately sedated or over sedated. And how do we prevent over sedation is, one is continuous monitoring. You have to see the patient's, observe patient's eyes, patient's response, and other methods, as I already told. If you're sedating for a long time, reduce the dose. Don't use higher concentration for a long time. And do not carry out most of the procedures. Try to limit it within 30 to 45 minutes. If you sedate for longer time, the patient will skip into the deeper stage of sedation. And a proper titration. Don't go in by increments.
Yes, doctor. As we said, one of the advantages why we are doing this procedure itself is we can reverse it at any point of time. We feel the patient is getting over sedated, we can slowly reduce the concentration, and that is how I think we prevent excessive sedation.
That's why clinical observation is very important.
Yes,
only based on that, you have to decide what concentration you're going to keep the patient on.
Okay. So shall we move on to the next question, doctor? The next question is by Dr. Arshia Khalid. The question is, what is the cost of the whole setup, nitrous oxide and oxygen?
Only nitrous oxide and oxygen. See, I'll tell you, when I bought the machine, now the cost has slightly increased for the machine. When I bought only the machine, it was around 2.5 lakhs. And then I had to do after some time, I told you the reason why I modified the entire unit to have a central supply for the oxygen. That costed me around 25,000 more. And in addition to this, I had to buy the extra suction unit. I had to change my entire clinic. So all those will be the additional costs. So if you have your entire clinic ready, only you need the unit, then maybe 3 lakhs will be enough.
Okay, moving on to the next question. Is lowering the dose the only way to reverse sedation?
To reverse sedation with nitrous oxide, yes.
Yes.
The only way to reverse is you have to reduce the dose of nitrous oxide.
Yes, and increase the dose of oxygen. Automatically it gets
automatically will increase.
Yes. Any drug interaction which we need to check before sedation? That is, what drug interaction we need to check before sedating a patient? Is asked again by Dr. Arshia Khalid.
Drug interactions, I told you, you cannot sedate in patients who are on cancer treatment, patients who are having B12 deficiency. And also, see, what I use is, it's purely nitrous oxide oxygen sedation. Nitrous oxide is used along with the other sedatives like midazolam, promethazine, it is used. But that will go into a more deeper level of sedation when you want to do it. And also, even the drugs like antihistamines, which will affect the CNS, which will cause the CNS depression. Actually, all the drugs which act on the CNS, which cause CNS depression, will have an additive effect on the effects of nitrous oxide. So that thing has to be checked. That is one reason, if the patient is having cold, they will be taking antihistamines. So it is better to avoid the nitrous oxide sedation at that time. You can do it once they finish their course or once they are fine.
Okay, doctor. Thank you for the answer. The next question is it mandatory to monitor carbon dioxide saturation as well along with oxygen, or oxygen alone is sufficient? That is, do we have to monitor carbon dioxide and oxygen, or only oxygen will do? Is the question posed by the doctor.
As far as I have read, as far as I am aware, saturation of only oxygen is enough, and that is what even I practice. I don't know how do you monitor the carbon dioxide concentration.
The next question, in patients with autism, is GA safe?
Is GA safe? See, it depends on the anesthetizing unit material what is used. You cannot use nitrous oxide is also used for GA, but you cannot use nitrous oxide for GA in these patients. So that is why it's better. We should have a consultation with the pediatrician and the anesthesiologist for this. But I think they can decide it's better. But nitrous oxide is not used in patients with autism.
The next question by Dr. Iftikhar Ahmed. In patients with DNS, you had mentioned a modified technique. Could you please elaborate on it?
Yeah, in that, what they do is, because the nasal mask, there is a nasal mask and there will be an inlet tube and there will be an outlet tube. So in that, they remove the nasal mask and they put the rubber dam, and only with the inlet tube, they pass it to it is passed under the rubber dam. So the inlet tube is directly into the oropharynx. So the gases are directly delivered inside the oropharynx.
I think this is probably the last question. Is NPO important for conscious sedation?
Most of the books and also AAPD, they recommend NPO. I have read one article where they have told that fasting will cause, in patients, they noticed that when the patients were kept on fasting, they had more vomiting. One of the articles says that, but most of the books and also journals, they recommend NPO for fasting, for sedation. And some have recommended for 2 hours. And some tell that water can be given until the procedure also. But if you ask the anesthetist, they actually recommend NPO for.
I think somebody needs to ask a question. Please go ahead. Dr. Sabah?
Yes, ma'am.
Are you available? Yeah, okay. Please carry on, Dr. I think there was some disturbance.
Yes, ma'am. That's what I told. If the anesthetist, they also recommend NPO for sedation.
So I think
treated children, the children of anesthetists, and they also have done it under this thing only. They have followed NPO, and they only told me that it is recommended. It has to be done.
So I think we have done with all of the questions.
We have one more question. We have one more question from Dr. Iftikhar.
Please, doctor.
Yeah, Dr. Iftikhar is asking, in patients with autism, is general anesthesia safe?
Yeah, we have asked that question, doctor.
We've already asked you that. Okay. Regarding, I just want to add on a couple of things. Regarding the question with the monitoring of carbon dioxide, I think the video which Dr. Sabah played was a very good and informative video, except that the couple of things are missing in the video. I think you need to, when you're giving a moderate sedation or a conscious sedation to any patient, whether being it a pediatric patient or an adult patient, you have to constantly monitor the vital signs, such as the oxygen saturation and also the heart rate and blood pressure. I don't know, maybe the video was not properly, visible, or maybe the BP meter and the pulse oximeter was attached to the patient, we do not know, but this is very important that we persistently and constantly overlook and then monitor the vital signs of any patient going sedation. And regarding thing about monitoring carbon dioxide levels, if you have a vital signs monitor connected to the patient, it shows both the carbon dioxide as well as the oxygen saturation levels. So in cases of there is hypooxygenation or hyperoxygenation, or there is excessive carbon dioxide accumulation, then you have to modulate the oxygen levels, the inhalation levels. Now, this is one thing. And the thing about NPO is, why is NPO important? The possibility, like you said, there's always a possibility of reflux leading to vomiting or nausea. This may lead to aspiration into the lungs. So this is the reason why NPO is preferred. I think the forum is open for other people if they have anything to add or comment or even ask.
The pulse oximeter is continuously used during the procedure. I use it even now. And also the pulse oximeter, when we use it, normally in children, for small children, it doesn't fit into the index finger. So sometimes we'll have to attach it to the middle finger. And also when we put it immediately, it will show the readings. But after some time it stops. It will just show that.
The safest place for pulse oximeter to be fitted in a pediatric patient is the bigger toe.
On the toe.
Yeah.
I have actually done that, sir. But they normally just, just keep moving it and they just keep
Yeah,
it.
you need to tape it. You need to tape it, attach
Yeah.
it, and then you need to tape it. Yeah. And is there a way of sedation by LMA, laryngeal mask airway? Have you heard of it?
Laryngeal mask airway.
The use of laryngeal mask airway for sedation?
I've not come
Okay,
across
this is advanced conscious sedation techniques. Yeah.
laryngeal.
Normally, the different techniques, like you already mentioned, was first thing is like oral, which you practice. The other one is transmucosal, which is again by use of nasal sprays or syrups. And the most important one is the intravenous.
So the laryngeal mask one, is it done by the dentist or?
It can be done, but if the dentist is trained in that particular advanced conscious sedation techniques, it requires excessive training and then and certification to do it. And the reason why you have to attach the monitors is in case of any untoward events, you can monitor it and you can catch it and then you can reverse the patient accordingly. So this is very important. I think you need to connect the patient to a BP meter or invest in a good vital signs monitor wherein you have everything, not just the pulse oximeter as a separate and then sphygmomanometer is separate. Vital signs monitor has everything, which includes the heart rate, oxygen saturation, carbon dioxide saturation, and the BP and the pulse rate, and also the respiration rate, along with the pulse oxygen saturation levels.
Thank you, doctor. Thank you so much for your inputs. I think we have another question by Dr. Rafia. Would you like to add anything on the previous question, Dr. Sabah and Doctor speaking, or should I proceed with the next question?
Proceed with the next question.
Okay, thank you. The next question by Dr. Rafia is, can conscious sedation be used in patients with a history of asthma or wheezing?
Yes, it can be used. Actually, what this says, one main reason why the asthma attack occurs is because of anxiety. So that's why giving nitrous oxide, it actually reduces anxiety. So the chances of asthmatic attack is very less. And also, since only the oxygen is given along with nitrous oxide, it is recommended it can be given in asthmatic patients. But always it is said that it's better to have your inhaler ready. And before you start the procedure, take about 2 puffs of the inhaler.
Thank you for your answer, Doctor. There's another question posted by Dr. Ramiz. The question is, how beneficial is it in an uncooperative child? If anxiety can be managed by counseling, then can it be a substitute for NOIS, nitrous oxide inhalation sedation?
See, as I told you, nitrous oxide inhalation sedation, it's not a substitute for your behavior guidance techniques or behavior counseling techniques. So most of these patients who have practiced nitrous oxide, all these were uncooperative patients, and some were uncooperative to the extent that they were not even ready to enter the clinic. So in those patients, what we do is we counsel them, and we do other tell-show-do techniques, do other behavior guidance techniques, and then get them to a stage where they can at least exit the mask and sit comfortably. And after that, you do the procedure. During the procedure, the patient is overall relaxed, and then see what happens is the patient would have agreed for the procedure. If the patient was very having definitely a negative behavior, you have counseled, they agree, they come, they go through the procedure. Sometimes the procedure will not be very comfortable to the patient. So next time they will not agree to come. If the procedure was comfortable, after your behavior guidance, the procedure was comfortable for the patient, they will not hesitate to come next time. Those patients, they come happily next time.
So
it is
basically, we opted
gen-
for patients with disruptive behavior.
Mm.
If you want, we can utilize that term for nitrous oxide inhalation sedation, which we try all the management techniques or the behavior guidance techniques and which we fail. And kind of, no, as I said, disruptive behavior, we can just put it under that terminology, then we probably go for this technique. Okay, would you like this to add on something, doctor?
Ma'am, thing is, nitrous oxide, no, it should always be used as, and it should not be limited only to patients who are who are having a very negative behavior. I feel it should be given to almost all unless the patient is having a definitely positive attitude behavior, it can be given even to patients with a mild negative behavior. Because I've seen children, sometimes they'll be very cooperative. First visit they come, they don't know what is going to happen. They come happily, they get the treatment done. But even the slight pain or slight discomfort, puts a negative attitude in them and they will not come for the next appointment. But what I've seen that patients who are treated under nitrous oxide, they will happily come for the next sitting because they do not feel the discomfort during the procedure.
Okay. So the last question, a note on absolute and relative contraindications for sedation.
The absolute, as I already told you, bleomycin therapy, cancer patients who have folate deficiency, who have methylene tetrahydrofolate deficiency, patients who have intraocular bubble and pregnancy, those are absolute contraindications. And relative contraindications is upper respiratory tract infection and mouth breathing. All these are, and even the disruptive behavior is one of the absolute contraindication.
Is neuromuscular disorder an absolute contraindication or a relative contraindication?
Neuromuscular disorders. In a sense, if the patient is not able to cooperate or sit for the procedure, if they're not able to hold the mask, then it's an absolute contraindication.
The patient should at least be in a position to kind of hold the mask
and sit in a.
To that level of cooperation we expect from the patient. So I think we are done with the questions. So if you like to add on anything more, Dr. Sabah, so that I can just conclude the session.
Done. Fine.
So thank you, Dr. Sabah. You gave us a spectacular presentation. Thank you so much for that. And I would extend my thanks to each one of you who have joined the session today for your patient hearing, for your very valuable inputs and showing so much of interest. And thank you, Team GDP, for creating this platform, which helps us to become better professionals, enhances our knowledge and sharpen our skills. Hope GDP comes up with many more such webinars in future too. So once again, thank you each and everyone who were present for this session. Thank you so much.
Thank you, ma'am.
Yeah.
Any more questions, they can add it on the group.
Yeah, any more? Yeah.
Okay.
Thank you so much, everyone. Thank you so much.